Good evening, everyone. My name is Dr. Deborah Duro. I'm a program director of pediatric gastroenterology and nutrition at Broward Health, Fort Lauderdale, Florida. I am a graduate in the Culinary Health Educator Fundamentals Chef Coaching Program at Harvard Medical School. I am happy to welcome you to tonight's webinar, Milk Protein Allergy and Lactose Intolerance, our fourth webinar in the new exciting series, Culinary Medicine. A special thanks to ByHeart, who has supported this webinar through an educational grant. I am proud to announce tonight, first presenter, Dr. Maria Mascarenhas is a pediatric gastroenterology in the Division of Gastroenterology, Hepatology and Nutrition at Children's Hospital, Philadelphia. She's an experienced clinician, educator, international speaker, and a widely published. Her research areas include cystic fibrosis, nutritional support, 22q11 2 deletion syndrome, and integrative medicine. In addition to her many publications, she has written a book, The Anti-Inflammatory Family Cookbook, to help her patients learn about and cook tasty and healthy meals. Thank you, Dr. Mascarenhas. The floor is yours.
Thank you so much, Deb, for that wonderful introduction, and welcome to all of you to this Culinary Medicine series. I'm really happy today to present to you. So these are my objectives, and Deb already mentioned that. So I'm going to start off with this slide that I'm sure all of us have seen, food allergy, right? So we divide it into IgE mediated, non-IgE mediated, and then mixed IgE and cell mediated. And I think we're all familiar with where the conditions that we see are in the various categories. Now, I like this slide because it really breaks down and shows us very clearly what the target is for these allergies, right? So immediate hypersensitivity is systemic, oral allergy syndrome is oral, and then EOE is in the esophagus, EG in the stomach and small bowel, food protein-induced enterocolitis in the rectum, allergic colitis in the rectum, sigmoid, and so forth. So, and on the right-hand side, you can see the symptoms, and in the middle, you can see whether it's IgE mediated or not. Now, I'm going to focus this talk on primarily three areas: food protein-induced enteropathy, food protein-induced enterocolitis syndrome, and then food protein-induced proctocolitis, allergic proctocolitis. So, I think we've all seen this many times, but it's always wonderful to do a little recap. So we know it's commonly seen in infants the first few months of life, often sometimes the first week of life. It almost always resolves by 1 year of age, but can extend a little bit longer. The prevalence really varies a lot. It's from 2 to 64% based on what study you use, what their criteria were. Did they need biopsies to prove this, etc. Oftentimes, there's frequent visible blood in normal or mucousy stools. Sometimes it's occult blood. Now, uncommonly, you can see patients with constipation, but with occult blood. In general, the babies are well appearing and happy, and you will get a history of family history of atopic disease. So either eczema, allergies, allergic rhinitis, or IgE-mediated allergy. Now, what are the dietary triggers? By far, cow's milk is the most common trigger, and it can come via breast milk or formula. Other reactions are also possible. So egg in 16%, soy in 6%, corn in 2%, and usually this is in infants with multiple protein allergies. And then you can get combinations of the above in about 8%. So some babies, however, will have no response to maternal dietary restrictions. And after more than 40 years in practice, I finally had one of those this past year. And this is actually 8%. And these infants improved after weaning to an extensively hydrolyzed or amino acid formula. But for those of you in practice, you know, if a kid likes breast milk, it's very hard to get them onto an amino acid formula, which is what this baby needed. And we won't discuss how I managed the patient, but let's say it's been tough. So what is the pathophysiology? So the exact mechanism is not known. One question is, does the orally ingested protein induce an inflammatory response limited to the colon and distal sigmoid colon? Another one is the offending protein may be bound to antibodies in the breast milk, and then the colonic bacterial enzymes cleave or release the antigen, causing the response. And possible causal factors in what we know, we don't know for sure, is either the immaturity of the immune system, altered intestinal permeability, maybe genetic predisposition, abnormal gut microbiome, and autoimmune disease. Now, the evaluation and diagnosis consists of really the history is the most important part. So this rectal bleeding, mucus, there may be increase in stool output in a well infant, and then you have to ask the maternal diet, get the maternal diet history for cow's milk, dairy products, soy, eggs, and corn in that order, and then also the formula history, what they were fed, what they're fed now. Physical examination is almost always normal. Testing is not necessary. That's why I bolded it. This is a clinical diagnosis. You do not need to do tests. But I put some things there in case you get tests, because sometimes parents want something done, and so the easiest might be to get a CBC. But you might see peripheral eosinophilia or a mild anemia based on how much blood and how long. The stool smear might show some PMNs, typically eosinophils. Fecal calprotectin is not helpful, so don't get it, because usually calprotectin levels are generally higher in infants less than 7 months of age. But you may consider it if there's no response and use your clinical judgment. Allergy testing is not recommended unless there's really moderate to severe eczema, and then consult with an allergist. And then endoscopy might be done in certain select patients. But by and large, it's a clinical diagnosis with empiric elimination diet, and then the response is how you prove that, make the diagnosis. Management. In exclusively breastfed infants, you will continue breastfeeding if the mother's willing to restrict diet. So first stop all milk products, including butter. Avoid goat, sheep, or camel milk because of the cross-reactivity. There's a popularity now of goat's milk, so tell parents that there's cross-reactivity there. Severe symptoms, if those are present, then you want to try an amino acid formula for 3 to 5 days while the mom pumps, discards breast milk to wash out the antigens for her body to maintain lactation, and then put the kid back on breast milk. Read the labels. Make sure parents read labels for all that they're eating, and I listed all those allergens there. And then if it's a complete elimination, most kids are better in 1 to 2 weeks. If you see visible blood, then it might take a little bit longer. I've seen kids have heme positive stools up to about 5 to 6 weeks later, and then they become heme negative. Only a few require elimination of multiple proteins. So start off with milk. If there's no response after 2 weeks, then do soy, egg, and then if no change, and switch to hydrolyzed amino acid formula. When you restrict all those allergens from a mother's diet, they're on a very restricted diet, and it is very hard. A lot of them lose weight, need to go on a prenatal multivitamin again, etc. Now, if a patient's on formula, either supplemented or formula fed, the next step would be an extensively hydrolyzed formula. Soy formulas are generally not recommended because there's a 15 to 30% cross-reactivity, and amino acid formulas needed about 5 to 8% of infants with soy and cow's milk FPIAP. Now, I saw this was actually interesting because, it's lovely when you prepare a talk, then you read about stuff that you normally would not have read about. And so patients who got Lactobacillus rhamnosus GG, actually, this might promote recovery or the acquisition of tolerance. Now, management, how do you manage these patients? Typically, protein is introduced around 1 year of age. And it's interesting, in a study that they did looking at allergists and gastroenterologists, we were more conservative. We reintroduced the protein at 1 year, whereas allergists usually do it after 6 months. And the setting would be, if they have typical symptoms, it can be home, gradual reintroduction. However, if they have severe diarrhea, vomiting, and dehydration, then it should be a hospital-based challenge, because there sometimes is an overlap in these patients with food protein-induced enterocolitis. Now, advancement, if it's a breastfed infant, the mother adds 30 ml of cow's milk or the equivalent to her diet, increases it in her diet by 30 ml for 5 days. Formula-fed infants or infants no longer breastfeeding, then you would add milk or the new formula to pumped milk and then gradually increase it. Sometimes you can switch a child directly to cow's milk at 1 year of age. Now, reintroduction, cow's milk is generally effective. If not, then you can try cooked or baked milk products first. And that's why for some of these kids, seeing an allergist might be needed. I have a general rule of thumb. and this is not anywhere, this is my anecdotal experience. If kids have other food allergies, then it's probably best for them to see an allergist around 1 year of age. But if they don't, then you can safely challenge them at home. And then if recurrence occurs, then resume dietary restriction for another 6 months and then retry. So some kids may take 18 months, even up to 2 years to get over this. And the prognosis is excellent. Most kids can actually tolerate cow's milk or soy milk products by 1 year. Now, really briefly, food protein-induced enteropathy, we don't know what causes it. It's usually non-IgA mediated, affecting the small bowel. Clinically, these kids have diarrhea, weight loss, and malnutrition. Cow's milk is the most frequent culprit food. Now, it's relatively rare, and I remember as many, many years ago as a junior fellow and then a junior attending, we would get one of these kids every year. They would come in pale, very pale, puffy, and lo and behold, you stop the milk, they got better. Now we don't see as many kids, and I wonder whether it's because it was more associated with formula use, and now we're seeing more breastfed infants, or more mothers are breastfeeding now. The laboratory findings are non-specific. It's pretty much what you would see with any kid with malabsorption, anemia I mentioned. Allergy testing is not recommended. It usually resolves by 1 to 2 years of age, and treatment is to avoid the offending food. I put this comparison. I think you can all read faster than I can see, and you'll have these slides. But I broke it down into clinical, trigger foods, testing, biopsies, and treatment. And the treatment is pretty much an elimination diet. We've gone over the elimination diet for FPIAP, but if you compare the two columns, you can see the clinical appearance is a little different. The trigger foods are somewhat similar. Testing, usually babies with FPIAP have normal labs. Challenges can be done at home, and the biopsies are clearly different, where you get more damage and villus atrophy in the food protein enteropathy patients. Now, really quickly about food protein-induced enterocolitis or FIPEs, two manifestations, acute and chronic. The acute typically presents in the first year of age with severe delayed vomiting or diarrhea. You need to have the major criteria, at least 3 minor criteria, and 15 to 20% present in shock. So the major criteria, and this is key, is repetitive vomiting 1 to 4 hours after eating the suspect food, and the absence of IgE-mediated skin or respiratory symptoms. Okay, so that one is kind of the cutoff, but some kids with IgE mediated, they can straddle that 1 hour mark, but definitely it's later than if they had an IgE mediated reaction. And then the minor criteria, you can read them again faster than I can say, but this is from a standard. I think this was a landmark paper that came out in 2017. Now, chronic FIPEs is harder to diagnose, and again, there's no testing for it. But this is intermittent vomiting and frequent watery stools that worsen or progress to poor growth, dehydration, and shock. The offending food is ingested chronically, so you have progressive intermittent vomiting with again, diarrhea, poor weight gain, and malnutrition. Typically, it's cow's milk and soy milk, but can be any food. In infants, it's those two foods primarily. There is no test. Once you avoid it, the kids get better, and when reintroduced, they have more of an acute reaction. And so we have a food reactions clinic, and sometimes it's looking at these kids over time and looking at their growth failure, and then kind of diving deeper into the exact history of what happened when, that you can make the diagnosis. So the differential diagnosis, I think, is a metabolic disorder, underlying immune deficiency, VUIBD, reflux, structural abnormalities. But again, if you're suspicious, you'll diagnose it faster. The management is the acute episodes is rehydration. Often these kids they'll get a letter so that if they have an acute reaction, they go to the ED, they get hydrated. Food avoidance, you avoid the food allergen. We guide food reintroduction, always support breastfeeding, transition to formula if needed, and always we want to maintain proper growth and nutritional status. Food refusal is not uncommon, and so it's 16.7% in 8-month-olds, 18.8% in 12-month-olds. So it's fairly common, and you really want to preserve normal feeding progression. Now, if the kids have FIPEs, if they have cow's milk induced, 40 to 50% will react with soy, 32% will react to solids or grains, and if they have solid-induced FIPI, 60% will react to milk and soy, 50% for another grain, and 80% will react to one more food protein. And on the right-hand side, I have the age and the lower risk, moderate risk, and higher foods. So if you're advancing the diet in a patient or having the mother introduce foods, you want to stick with the lower risk foods before you move to the right-hand side of that table. The prognosis is in general good. It varies worldwide, and I've listed there the data we have from Korea, US, Israel, and then solid food. But you can see, by and large, kids will get better by 4 years of age. So some it can persist later. Okay, switching gears to lactose intolerance or lactose malabsorption, a lactase deficiency. I put these terms there because sometimes patients will come to you confused and you have to kind of go over and help them understand. So lactose intolerance, basically after you ingest GI symptoms, after you ingest lactose or lactose-containing foods, if they have malabsorption, that's incomplete absorption of lactose, and so lactose reaches the colon, and lactase deficiency basically is the lack of activity of the enzyme lactase. So how common is it? It's really worldwide. And there's the lowest prevalence in Europeans and European Americans, highest in African Americans, Asian Americans, and Native Americans. And there are tribes in Africa where they have very high rates of lactase deficiencies. In general, the prevalence of lactase deficiency in children is low in children younger than 6 years. It increases with age. And we see that I think the African American, Asian, and Hispanic kids tend to have a little younger, but under 5, but otherwise most kids are over the age of 5. The physiology, so lactose is the predominant carbohydrate in infants, and intake falls as weaning foods are introduced and then reaches adult levels of lactose ingestion, which is much less than infant amounts. The lactose is hydrolyzed to glucose and galactose, absorbed by a sodium-dependent glucose carrier, and the unabsorbed lactose passes in the colon because it's converted to short-chain fatty acids and hydrogen gas, and that's it. So lactase is located on the tips of the villi, and what I highlighted was an interesting fact. So in patients, and you may or may not know this, but in patients with low small intestinal lactase activity, the colonic bacterial flora can adapt to persistent lactose ingestion and thereby contribute to a reduction in the incidence and the severity of symptoms following a lactose load. So if someone has lactose intolerance, you can go on a strict diet, obviously, but if you have a little bit of lactose coming in, you find that they tolerate it. So with yogurt, a lot of patients will tolerate it. And so that actually helps with when they're going out and their ability to tolerate some lactose in whatever dish is being served, and they want to eat some of it. So the etiology, it's primary or secondary. Primary can be congenital or acquired or developmental. Congenital is a very rare autosomal recessive disorder. This is on the board exam. Infants will have diarrhea from birth. They may have hypercalcemia and nephrocalcinosis. It's common in the Finnish population, and there's absence of lactase activity, normal histology, and other disaccharidases are normal. For the acquired, this is an autosomal dominant trait, genetically regulated reduction of lactase enzyme with age, and the majority of the world's population, as I mentioned earlier, will develop this at preschool age, most common in Asian and African populations. Developmental is prematurity, and as the babies become term, things improved. Secondary is usually when diseases damage mucosal surface area, and I'm sure all of you are familiar with celiac disease and inflammatory bowel disease, or even post-viral damage to the small bowel. Lactase is usually the first disaccharidase to be affected, predominantly because it's located on the villus tip, and lactose digestion is also affected because of lower reserve capacities compared to the other disaccharadases. So important points. The clinical features, you have kids who have positive breath tests but are asymptomatic, and they can be symptomatic with crampy abdominal pain, diarrhea, borborygmi, and these patients should not have weight loss or other nutritional deficiencies, so think of something else. The diagnosis can be made clinically, resolution of symptoms within 5 to 7 days of avoidance of a lactose-containing food. We never check stool, but if you check stool, that's what you would find. A hydrogen breath test, which I put on the right side, is a common way of diagnosing this. And then obviously disaccharide analysis and a small bile biopsy. But I think you can make a clinical diagnosis. You don't have to go to testing unless you have other confusing things in the picture. The management is pretty much eliminate symptoms, maintain calcium and vitamin D intake. If they're asymptomatic, leave them alone. If they're symptomatic, then you either do a lactose-reduced diet or a lactose-free diet. Yogurt is often tolerated. If you use lactase enzyme supplements, it's a clinical decision. And these lactase commercial products usually come from bacterial or yeast beta-glucosidases. And then if it's secondary, treat the underlying disease. And if you have persistent symptoms, look for other diseases. I put this table here just because this might be useful to help differentiate between lactose intolerance and cow's milk allergy. As you can see, the mechanism is different, the onset of symptoms is different, the resolution is different, the food component involved is different. In lactose intolerance, you need grams of lactose, whereas in cow's milk allergy, you need nanograms to milligrams. The GI symptoms are what we talked about for lactose intolerance, and then for cow's milk allergy, it depends whether it's IgE mediated or non-IgE mediated. There are extraintestinal manifestations with lactose intolerance as well as with cow's milk allergy, but they're different. And then the testing is also different, but the dietary treatment is elimination. So in conclusion, milk protein allergy and lactose intolerance can be distinguished from each other, and the treatment is diet elimination. And thank you for your attention.
Wonderful. Thank you, Dr. Mascarenhas. Very comprehensive talk in a very short time. Amazing. Next, we have Olguine Fernandes Fraga. She's a registered dietitian and is board certified in tube feeding and pediatric nutrition. Her nutrition philosophy is about making nutrition easy to understand and easy attainable to all patients. And she focuses on the art and the science of nourishment and sustainable changes. Olguine, please.
Thank you. I'll be speaking on key nutritional considerations for children with milk allergy or lactose intolerance, focusing on considerations for growth and nutrient intake without dairy. I have no disclosures. Milk allergy and lactose intolerance can require different dietary approaches. Milk allergy requires excluding all milk products, while lactose intolerance involves avoiding lactose-containing foods. Advising child and caregivers to just avoid milk misses the important nuances of their dietary needs. Without thorough education, a dairy-free diet can lead to reduced satiety, a restricted diet, suboptimal growth, and nutrient deficiencies. It may also impact social interactions, add mealtime stress, and create financial strain. Given these potential risks, it's essential to know which nutrients dairy provides to ensure a balanced transition to a dairy-free diet. Let's start with calcium. Calcium works synergistically with vitamin D, phosphorus, and K2 to play key roles in bone metabolism. Calcium also supports muscle movement, nerve signaling. Vitamin D helps manage inflammation, support glucose metabolism, and immunity. Phosphorus aids in cellular function and pH balance. K2 directs the calcium to the bones. B12 supports energy metabolism. Iodine supports the thyroid, and protein promotes muscle growth, promotes satiety. It's the building block for hormones, enzymes, neurotransmitters, antibodies, and more. When certain nutrients are lacking, the body may start to show signs of deficiency. Calcium, vitamin D, phosphorus, and K2 deficiencies can lead to bone and dental issues, muscle cramps, and a weakened immune system. In vitamin D deficiency, we may also see weakened immunity and issues with glucose metabolism in young children. A vitamin D deficiency can also delay their ability to walk. Phosphorus deficiency can also cause fatigue, weakness, anxiety, poor growth, and even altered mental status. Vitamin K2 deficiency can lead to calcium depositing in soft tissue instead of to the bones. And with B12 deficiency, we may see fatigue, anemia, glossitis of the tongue, poor appetite, and dyschezia. In younger children, we can see developmental delays, regressions, and hypotonia when we're expecting a little bit more muscle mass. Iodine deficiency can present as a goiter, unexplained weight gain, fatigue, cold sensitivity, and cognitive issues. An inadequate protein intake can result in thinning hair, brittle nails, swelling in the abdomen or extremities, brain fog, mood changes that resemble anxiety or depression, persistent hunger, and a weakened immune system. There's also the risk of deficiencies in riboflavin, typically skin cracking at the mouth corners, vitamin A, where there may be eye issues or bumpy skin, choline, where we may see early signs of fatty liver, and dairy-free children may also get less potassium, fatty acids, and probiotics as well. Because dairy is a key source of these nutrients, removing it from a child's diet without education increases the risk of deficiencies. One concern is that most plant-based milk alternatives aren't nutritionally equivalent to cow's milk, and nutrient content varies by brand. For children already starting with limited diets, swapping to some plant-based milks can further increase nutrient gaps. Let's take almond milk, for example, because it's one of the most common swaps that I see in practice. It contains very little protein and lacks key micronutrients, not pictured here, but for example, riboflavin and choline. And even when fortified, the nutrient content can vary by brand. Additionally, almond milk tends to be lower in calories and healthy fats, which are needed for growth and development in children. When we compare the protein content in milk versus milk alternatives, at first glance, it seems like a few of them are not far off, but let's take a closer look at the bioavailability of proteins. Not all proteins are created equal. When choosing protein sources, it's important to consider the protein efficiency ratio, or the PER. This ensures that the protein is not only abundant, but also effectively used by the body. For example, proteins from meats, seafoods, and dairy typically have a higher PER compared to plant-based proteins, meaning the body can absorb and utilize them more efficiently. This especially becomes a concern for children that don't eat animal proteins. Children eating primarily lower PER sources of protein will need more of those proteins to compensate. And just as with protein, the bioavailability of other nutrients like calcium is key in determining how effectively the body can use them. Calcium is abundant in many foods, but bioavailability varies based on the source. Plant-based foods can be high in oxalates, phytates, fiber, and phosphorus, which can inhibit or compete with calcium absorption. Taking a look at this graph here, for kale, for example, it has the highest calcium bioavailability, likely due to being low in oxalates, phytates, and phosphorus. Now let's take a look at non-dairy food sources of those key nutrients. For calcium, options include canned fish with bones, kale, as we just saw, tofu, fortified plant-based beverages. Some vitamin D can be obtained from fish, cod liver oil, and fortified foods. Phosphorus is found in protein-rich sources like salmon, chicken, lentils, cashews. Vitamin K2 is present in certain fermented foods, egg yolks, and certain meats. B12 is primarily found in animal products like liver, fish, and some fortified foods. Iodine is found in seafood, iodized salt, and eggs, and iodine fortified foods. And protein needs can be met through meats, seafood, and with less bioavailability, as we saw, legumes and some grains. Taking a look into food sources of additional nutrients and their non-dairy sources. Riboflavin can be found in beef or chicken liver, fortified cereals, steak, almonds. Vitamin A is also found in liver meat as well, as foods like sweet potatoes, spinach, carrots. Choline is also found in liver meat as well as found in eggs, soybean, fish, quinoa, and more. Good sources of potassium include lentils, apricots, squash, oranges, spinach, and more. Fatty acids come from fatty fish, oils, nuts, seeds, avocado, and probiotics are present in plant-based yogurts and fermented food that specifically the fermented foods that include probiotics like kimchi, sourdough breads, and sauerkraut. And by incorporating a variety of these foods, a well-balanced dairy-free diet can be achieved. And when managing a dairy-free diet in pediatrics, it's important to consider nutritional needs at different life stages. So in infancy, breast milk is ideal with maternal avoidance of dairy if required. For patients requiring the non-standard formulas, the options include hydrolyzed or amino acid-based formulas, and in rare cases, plant-based formula like soy base. And as solids are introduced, the focus should be on non-dairy sources of food. In toddlerhood, the transition to dairy-free milk begins with fortified options, such as soy or pea milk being the most nutritionally comparable to cow's milk. And at this stage, diet trying to prioritize nutrient-dense foods that they will eat is crucial to support their growth and development. In children, the emphasis remains on, in childhood, the emphasis remains on nutrient-dense foods while expanding the dietary variety. Navigating school lunches also becomes an important consideration and contributes to caregiver stress. For adolescents, peak bone mass development starts around puberty. So approximately 50% of the bone mass that we all have as adults was developed during puberty. So therefore, we have to make sure that they're meeting those increased nutrient needs, especially with calcium, vitamin D, phosphorus, and K2. The social and psychological aspects of food choices and dietary adherence also become more prominent during this time period as well. Let's review some practical strategies for milk allergies and lactose intolerance. Reading ingredients, that allows us to be more mindful of ingredients that may not outright say milk or lactose. So for example, they could say things like butter, whey, casein, hydrolysates, galactose, or rennet. And the easiest thing to do for a family that's new to this diagnosis is to look at the bottom of the ingredients where they typically have a contains milk or may contain milk to clearly warn the consumers of the risk. In the US and Canada, another way to verify is to refer to the kosher label on packaged foods to distinguish dairy-containing foods versus dairy cross-contamination versus non-dairy foods. For social events like parties, the patient and caregivers can request to bring their own food. And if they want to be a little bit more discreet, they can offer to bring dairy-free entrees and appetizers to share with everyone and have the patient just kind of focus on eating those unless they are able to verify the safety of the other available foods. Some patients are able to take a lactase enzyme, and whether they want to be open or discreet about it is going to be up to the patient and their caregivers. As far as available options go, for milk allergies and lactose intolerance, there's plant-based milks, yogurts, and cheeses. However, caregivers must remember that they may not be nutritionally equivalent, but can still fit into a balanced diet. For lactose intolerance, there is lactose-free milk, cheese, and yogurt, and they tend to be more nutritionally similar to regular cow's milk products. And swaps aren't always simple, but there are options for both milk allergies and lactose intolerance, depending on the use. So for butter, for example, it may be possible to use avocado or dairy-free spreads or oils. For ice creams, it may be possible to use sorbets or other plant-based frozen desserts. Caregivers can seek dairy-free recipes, and then modifying existing family recipes will require substituting individual dairy ingredients. And of note, just as Dr. Mascarenhas said, other mammalian milks, for example, goat and sheep's milks, are not gonna be suitable alternatives because there can be cross-reactivity and they also contain lactose. To accommodate dining out, patients can review the menu online, call ahead to confirm lactose-free or dairy-free options, and clearly communicate with the server, especially if there's a risk of anaphylaxis. Vegan menus or vegan restaurants are typically safe. And if not available, then low-risk options include plain grilled meats and seafood, oil and vinegar for salad dressings, plain French fries, fruits, and plain steamed vegetables. In conclusion, dietary variety is crucial for children avoiding dairy to support their growth and development. It's all of our responsibilities to monitor for signs of suboptimal nutrition. So all providers should track growth, screen for nutrient deficiencies, and assess bone health. We should also inquire about their dietary variety and provide updated documentation that they might need for school, such as accommodations for school lunch if they need lactose-free milk or a plant-based milk. If medically appropriate, reevaluate the child for dairy reintroduction, especially if that cow's milk protein allergy was diagnosed in infancy without a trial of cow's milk in childhood or adolescence. And then refer the patient to a dietitian for education once diagnosed, or if it's suspected that they're having difficulty meeting their nutrient needs. And if there's a noticeable psychological impact, consider referring the patient and caregivers to a therapist or a support group for additional support.
Thank you again. Very good. Our final presentation this evening is from our medical chef, Vanessa Weisbrod. Vanessa is the Chef Education and Community Engagement Office at the Celiac Disease Foundation, where she drives change in healthcare through education. In addition, she's a certified medical chef through the Harvard Medical School Culinary Chef program as well, and has authored more than 4 books, gluten-free cookbooks, actually. Wonderful, Vanessa. Let's go for the fun part of the culinary webinar.
Hi, I'm Vanessa Weisbrod, and I'm excited to welcome you into our kitchen today to talk about dairy-free and lactose-free cooking. This is a topic that is very near and dear to my heart. My own son has an anaphylactic dairy allergy, and more times than I can count on my hands have we had issues with getting the appropriate dairy-free accommodations that he's needed when we're out of the house. So I hope that today you'll learn a few important points to help your patients and families navigate these issues. So before we get into cooking, we're going to be making 2 amazing recipes today. First, a creamy pasta sauce served with chickpea pasta, and then a delicious dairy-free ice cream with some fun additions for the kiddos. But before we get to those recipes, I want to talk about the differences between a dairy-free diet and a lactose-free diet. So a dairy-free diet is one that excludes all products that are derived from milk. This means dairy is the protein, so the casein protein is what a person with a dairy allergy cannot tolerate, and so it has to be completely free of casein. Lactose, on the other hand, is the sugar that's found in dairy, and a product that is lactose-free is not necessarily also dairy-free, and so it's a really important distinction. So let's take a very common example, sherbet and sorbet. Sherbet, though it's made with not necessarily heavy creams like ice creams are, it's still made with milk and contains the dairy casein protein. On the other hand, sorbet is a dairy-free alternative that has no dairy products in it. So if you have a dairy allergy, you could have the sorbet. However, there are many sherbets that are actually made using lactose-free milks, and so somebody who can't have lactose may be able to eat some of those sherbet products made with a lactose-free milk. But it's a very important distinction to remember when you're managing one of these diets. The good news is that there are lots of substitutions for both dairy-free cooking and lactose-free cooking. There are great milk alternatives. Almond milk, soy milk, coconut milk, or oat milk are all wonderful dairy-free and lactose-free alternatives. There are awesome cheeses. I even have a block here of dairy-free cheese. This is actually made from coconut oil. You can get different cheeses made from nuts, soy, coconut, and they taste delicious, and many of them actually melt pretty well too. This is a very important thing though. Some of these cheeses may contain dairy or lactose, so always double check the labels before picking the one to make sure that it works for your family's specific dietary needs. There's also lots of alternatives to butter. We're going to be using avocado oil today, which is a fantastic replacement that works for all dairy-free diets. You can also use things like avocado oil or coconut oil. So let's get started cooking. So today we're starting with our creamy pasta sauce with chickpea pasta. We have a magic ingredient to make it creamy because we're obviously not going to be using any milk or cream in this pasta. Our secret weapon today is eggplant. We're gonna roast this eggplant up and then we're gonna puree it with all the rest of our vegetables, and it's going to make the most delicious creamy pasta sauce. So what's fun about today's recipe is that nothing has to be exact. And you're gonna see later when we puree it that this is all about the ingredients. So these are all fresh ingredients. I'm gonna slice this eggplant into some rings here. Again, it does not have to be perfect. I'm not exactly measuring the size, just slicing it up so that we can roast it. The one thing that we do want to think about is that eventually this is going to go into the blender. This is a pretty big eggplant, so I'm going to cut it in half just so the pieces aren't quite so large and put them on our baking sheet. Again, it does not have to be perfect. Oftentimes when you're cooking eggplant, you're gonna wanna salt it and let it sit first. For this particular recipe, I'm not going to do that. It's all going to get pureed together, and we actually want some of that extra moisture in it to help loosen up the sauce at the end. Important point, I will say this again later when we get into the pureeing. Once these vegetables roast, there's going to be a lot of juices on the pan. Those juices are packed with flavor, and we want to make sure that all of them get into the blender so that those flavors are part of our sauce. So in addition to the eggplant, I have 2 pints of grape tomatoes. Again, these are going to have different amounts of moisture in them, dependent on when you picked them from your garden or how they came into your grocery store. They're all not going to have the exact same amount of liquid in them. So when we go to puree them, we're going to add some chicken broth to them, and the amount is going to vary depending on your veggies and how much moisture is in them. We also have some baby carrots. You can use bigger carrots, whatever you want. We just want to get some of that great carrot flavor in there. And then onion. So onion brings great flavor to sauces. It's in almost every Italian pasta sauce. Just like the eggplant, I'm just going to roughly chop this up. It does not have to be perfect. They're just some moons here. We'll spread them out on our tray. And finally, some garlic. Garlic goes in every sauce. It has so much flavor in it. And to get even more flavor out of this garlic, we are going to roast it. I'm not going to put the garlic directly on the sheet pan because we don't want it to burn. We're cooking this at a high temperature to bring all those flavors out of the veggies. If we cook the garlic at the same temperature without foil over it, it will burn. So we're going to put it inside some foil. And I'm going to take some of my avocado oil and drizzle it over the garlic, and just a teeny pinch of salt with it. Wrap it all up, and as soon as our tray is ready, we'll put that on the tray. So now we have to prepare the veggies to go into the oven. I'm going to drizzle all of these with some olive oil or avocado oil, and just a little bit of salt. We will toss it all together to get them nice and coated. Again, this does not have to be perfect, but we do want to coat the veggies with the oil and the salt. Try to make as even a layer as possible just so that they're not stacked on top of one another. And then we will put this in the oven to roast for about 20 to 25 minutes. You'll know that they're done because they're nice and golden and very soft looking. So I'm going to pop these in the oven. I'm going to get our chickpea wheels pasta on the stove, and we'll be right back. All right, so our vegetables are out of the oven now. You can see our roasted garlic. It is nice and soft and perfect to puree. So I'm going to go ahead and dump that into our blender, and again, making sure to get all of the juices of the garlic out of there so we get that flavor in our sauce. And then I'm simply just going to take all of our veggies and put them into the blender. And I want you to remember as you are eating this, that this isn't just a tomato sauce that's filled with salt and sugar, because there's actually no sugar in this sauce at all. But this is a creamy veggie sauce that is made entirely of pureed vegetables and herbs. So it's actually really good for you as you're sitting there eating your dinner. So I'm going to add just a little bit of our chicken broth to this. And again, I'll adjust it as we go to get the desired thinness that I want for the sauce. Here we have our Italian seasoning, some paprika, and my favorite ingredient, basil. I'm going to put some of the basil in now, and then after it's pureed down, I'll add some more to it. Okay, so we just did the first puree. It's right now, the consistency is more like salsa than like pasta sauce. And so I'm gonna add some more of our chicken broth to this to thin it out. I want it to be thin enough so that it's going to coat the pasta in a very nice way. I'm gonna add some more basil in as well. And a little bit of salt. Again, everyone is going to want a different amount of salt. I don't like overly salty things, so I'm just going real easy on the salt here. I think we're getting very close. Just a little thinner, and I think we'll be perfect. So I put in about 1 cup of chicken broth in total here. Again, it will vary based upon how thick you want your sauce to be, but this is about 1 cup. All right, so the final step is just to put it on our pasta. We have our cooked chickpea wheels here. These are my kids' favorite shape of pasta. It's fun, it tastes good, and they're adorable. So we're just gonna take the pasta and we will top it with some of our sauce. If you weren't going to serve this right away, you could put this into a pot to keep it warm on the stove, but we are ready to eat right now. So we're gonna put this beautiful creamy pasta sauce right on top of the noodles. And as a special treat, we have our dairy-free Parmesan cheese. So I'm just gonna grate a little bit of Parmesan right on top of here. This is an extra special treat. All right, we are ready to eat. It's time to make dessert, and today we are making one of the most easy to make dairy-free desserts I have ever had. Today we're going to make a dairy-free berry ice cream, and it's so simple. It uses only 4 ingredients. We're using frozen strawberries, frozen bananas, a little bit of honey, and some coconut milk. I like the taste of coconut milk in my dairy-free ice cream, but you can use any dairy-free milk that you like. Almond milk is fantastic, oat milk is fantastic, but pick any milk that you enjoy. So this is really, really simple. All we're going to do is take the frozen fruit and put it into the food processor. You could also do this in a blender with not frozen fruit, just right out of your refrigerator, and then put it in an ice cream maker if you have one. But just to be quick and easy, we're doing it in the food processor today. So I'm gonna add in my honey. You could also use any sweetener of your choice. I like honey, but you could use sugar or any alternative sweetener that you enjoy. And then the milk. So I'm not gonna add in all of the milk all at once. This is about a cup of coconut milk. I'm only gonna add in about half of it, and then it's gonna really depend on how frozen and solid my fruit is to get the desired consistency. So add it in gradually so you get that texture that you want. But we do need a little bit in there to help the food processor get going. We're gonna pulse it just a little bit to get those pieces that are still stuck in there. All right. And you can see in just a few minutes, you have a delicious dairy-free dessert. We're gonna go ahead and scoop it into our bowl here. We'll do a double scoop. It's a dessert kind of day. And then we can top it off. So today I have chocolate chips and then some beautiful gluten-free, dairy-free, allergen-free unicorn sprinkles that we are gonna top this with. We'll start with some chocolate chips, some beautiful sprinkles, and top it with our unicorns. And there you go, a perfect dairy-free dessert delight.
Thank you, Vanessa. Thank you to our presenters. Amazing, delicious. So now we move to the Q&A portion of the webinar, and you still can submit your questions. Just scroll down in the window player, and you can submit your questions through the box. So let's start with Vanessa. Vanessa, tell us about the techniques or ingredients that you can recommend to replicate the rich, creamy texture on dairy recipes without compromising flavors.
This is something I have spent a lot of time thinking about over the last 8 years with my son. To get a really creamy texture without dairy, I like to use nut-based creams, like cashew cream or coconut cream, and you can make these at home. So to make a cashew cream, for example, just soak the cashews overnight. I typically do it overnight, and then blend them with water until they're very, very smooth, and it makes a really versatile base. You can actually buy coconut cream at the grocery store now. There are lots of different brands that are available in really small sizes or in your normal can size as well. And it's a mild sweetness that works great, especially for desserts. To thicken things up, I typically will use either arrowroot or tapioca starch because they don't change the flavor. And then, like you just saw in the cooking video, eggplant is a great vegetable to roast and puree to get a super, super creamy sauce. But the thing that I think is most important when you're cooking dairy-free is to use the right herbs and spices. That a lot of these ingredients just on their own don't have the perfect flavor profile. And so, using, natural spices, I like to grow them in my backyard or even in my kitchen window. Even during the winter, you can grow spices in your kitchen window. It's really important to integrate those really wonderful flavors into it. So, even if it's creamy, you still want it to taste delicious.
Very nice tips. Wonderful. Dr. Mascarenhas, you mentioned that stool test not to be used for lactose intolerance. Is there ever any utility on ordering fecal reducing substances?
I order fecal reducing substances when I suspect carbohydrate maldigestion, and I'm trying to differentiate between different conditions. So that's when I order it. But for lactose intolerance, no, because you do the diet elimination or reduce the lactose, and the kids get better soon.
Okay, wonderful. Thank you. Ogin, this one is for you. How much calcium does a child need and how they can get if they don't drink milk?
Calcium requirements will vary by age. From infancy, we can see between 200 and 260 milligrams per day. For toddlerhood, about 700 milligrams per day. For 4 years of age to approximately 8 years of age, we'll see about 1,000, and then 9 and up is going to be 1,300 milligrams per day. And the best ways to get calcium are going to be from those canned fish, for example, with the bones, like sardines and salmon. Typically, these bones are soft and edible, and we can digest them with no issues. Foods that are using calcium during the processing, such as tofu. And then we have kale, for example, cabbage and broccoli from the brassica family, where they tend to have a lot more bioavailability compared to spinach, because spinach does have more calcium than kale and cabbage and so on. But the bioavailability is low because of the fiber and the phytates and oxalates.
Very good. So let me ask about tofu here. So for milk protein allergy, being a soy base, right, cheese, I would love to hear your take. Vanessa, Dr. Mascarenhas, please use tofu as a substitution.
I mean, I do use tofu a lot as a substitution. Not necessarily always in the dairy-free recipes that I use, but I mean, I do use tofu a lot in cooking.
Yes.
I think there's a place for everything, and depends on your cultural background. So if your culture, you're used to having more tofu, then it's gonna come into all your food. I love tofu because I'm a pescatarian at this point, and so that's a wonderful for me to get protein in my diet. I think you have to be careful with the younger kids with the cross reactivity between milk, cow's milk, and soy. But older kids, I think there are wonderful recipes that you can make. For example, Vanessa, you can make a tofu scramble in the morning for breakfast. Put it in a quesadilla, put it in a wrap, and then becomes a nice snack. You can get very creative, I think, depending on, again, I think as Vanessa said, tofu is very bland. So it depends what flavorings and what spices you use with how you cook it. So I think I learned so much from what Vanessa showed me today that I think culinary medicine is fun. And so I think we should have fun with the food, given what we know our kids and ourselves can tolerate.
Wonderful.
I would add, though, that when you think about like the blandness of tofu as a product in general, that you can flavor it really, really well. And, you can fry it, you can air fry. I air fry tofu a lot with, just coating it with a little bit of cornstarch and seasonings. But what I think is really interesting is that the products that are dairy-free replacements that are made from tofu, they don't taste as great as, some of the others. And so I've found that, at least in my sample of kids that try them, that tofu goes better when it's homemade as opposed to necessarily a purchased product.
Oh, coming from a chef, a homemade tofu is amazing. I can imagine. Delicious.
I've never tried to make homemade tofu. But Vanessa, if you add it
I'll
to
make it for you.
if you add it to Indian curries, it's really good.
Yeah.
Wonderful. But I think Dr. Mascarenhas had a very important point with the tofu is to be careful to use for kids with milk allergy for the cross reactivity. But aside of that, it's such a versatile food for lactose intolerance and so on, right? So Vanessa, how you modify these traditional dairy-heavy dessert recipes, such as cheesecake, cream pies, to create a dairy-free version? And like you still have this texture.
Yeah, so it's something that takes a lot of practice, but there are lots of good recipes out there. And maybe for a future webinar, we will do a dairy-free cheesecake for everybody. But again, for desserts, I really do love the blend of cashews that I've soaked overnight with coconut cream. I just think that the taste profile for those are so delicious together that people really don't know the difference and actually, may enjoy it more. I think it's really the only way to get that like traditional velvety consistency for a cheesecake. And then, for the crust, a lot of pie crusts use dairy in them, and the butter replacements aren't always perfect. And so I tend to use crusts that are made from just like crushed nuts and dates, which have, a natural sweetness to them and, just taste absolutely delicious.
Oh, very nice. Ogin, I think you suggested maybe like French fries in one of your things for lactose free as one option. Just one question, very interesting. And actually someone mentioned fries were mentioned as a lactose free option. McDonald's fries have lactose and many are not aware. Many people are not aware. So very important to read the labels like you suggested and look for the ingredients that are not just saying milk sometimes, right? But contain lactose and other things. Very, very important. You want to comment on anything of that, of reading labels for patients with those conditions?
Yes. It's definitely a tricky space to navigate because sometimes the lactose or dairy could be present in things that we are never really suspecting. So the McDonald's French fries is a great example. Sometimes seasonings could, potentially have dairy or lactose in them as well. So really just being very diligent about reading the ingredients. And if it's like a bigger chain restaurant, they'll have that information available on their website for you.
Mm-hmm. Very, very
I think that's a really important point. So if you have a kid who's doing really well on a lactose reduced diet and suddenly they start having symptoms, they need to go and check what they're eating. Or if the recipes sometimes change, and you may have to go back and look to see if, like I remember once there was a hot dog brand that had lactose in it. And I was like, oh, that's why you were not doing well. So you really have to be careful because the ingredients recipes can change. And so really good point again. Yeah.
very
And
good.
this also goes for the gluten-free products that you would never expect to have dairy in them do. And so this happened just last week. I was at an event where we were helping with checking the ingredients, and the pizza crusts, which typically do not have dairy in them, actually had non-fat milk powder in them and eggs. And so two ingredients that are not common in pizza doughs that would normally, be served in mass quantities. That was a big red flag for those families that needed to avoid dairy and gluten.
Can I ask Vanessa a question?
Yeah.
Please,
So,
please, absolutely.
Vanessa, sometimes parents want to find the ingredients, and it's not easy to find on the label. Or how do they track things down? Or they've been using a product that's worked really well, now it's not working, and they're concerned that the manufacturer, something, there's cross contamination in the factory. How do they get after that?
Oh my. So this is a whole nother webinar, but so labeling has come a long way, and the labeling laws are good in that, if there is dairy in a product, it does have to be on the label. However, there are also all of these products now that never had dairy in them that now say may contain, milk, peanuts, tree nuts, soy, wheat, and all of the things, even though none of them are in the actual ingredients label. And so these are legal disclaimers, and it's really hard to know what they actually mean, and they do mean something different at every company. And so there really is a burden on families to check every single time. I have one child with a dairy allergy, I have one child with celiac disease in my house. And every single time I grocery shop, no matter what, I have to check the labels because products change, formulations change, and they're not required to tell you that. They don't send out a news flash, every time I go into Wegmans that, my products have changed and there's not like a red flag on the shelf. And so really it is a responsibility that we have to take as parents and caregivers to kids who have dietary restrictions, that every single time we grocery shop, even if we've bought that product 50 times before, we have to check the label.
Very good. Well, ladies, I can see the passion here, and then we can spend the whole night discussing culinary medicine. I want to thank you again for the time and the commitment for this important webinar. And please make note to visit the NASPGHAN Learning Center, where you can find on demand the versions of 3 previous webinars in the series: Wellness and Prevention, Blended Ice Tube Feeding, and Eosinophilic esophagitis. And mark your calendar for March 19 with Crohn's disease. So to our audience tonight and my speakers, again, thank you for participating, and everyone have a wonderful evening.